Now moving on to the next case, that is of a 48-year-old man with type 2 diabetes for 6 years, asymptomatic but TMT positive on animal testing. For this case, I'd like to invite our moderator, respected Dr. Sarita Bajaj ma'am. She's a consultant endocrinologist, director professor and head of the Department of Medicine at MLN Medical College at Prayagraj. I'd like to invite our panelist, Dr. Mandeep Singla, who's the assistant professor at the Department of General Medicine at GMCH Chandigarh, and Dr. Faraz Ahmed Faruqi, who's the assistant professor at the Department of Cardiology at VMMC and Safdarjung Hospital. So now I'll pass on the mic to the moderator, Dr. Sarita Bajaj ma'am.
Very good evening to all of you. We didn't want to have a mess up in the middle, so we thought we'll sort it out here first. So this is a very, very interesting case scenario. And as you can see, we have with us a cardiologist and an endocrinologist, and they've both been introduced to you. So they're both very keen to help us with this patient. Right? So I want all your inputs also. We are going to ask questions here. You're allowed to ask questions in between as well. Anytime you can get up. I'll be able to hear you, I promise you. My hearing is quite sound as of now. And we want a very, very good interaction here. Is that okay? So we have Mandeep with us and we have Faraz with us. They are going to help us with this 48-year-old male. It's a very, very common scenario. Long-standing diabetic on the same metformin glimepiride, non-hypertensive. That's a bit of a surprise here. He's a totally asymptomatic, unremarkable personal and family history. And he has this insurance, so he gets an annual cardiac checkup. Everything looks okay. Blood pressure is fine. I've already said he's not hypertensive. Systemic exam is within normal limits. But let us look at his metabolic parameters. You'll agree that the fasting and the postprandial and the A1C are deranged, as well as his lipid profile. Okay, it's totally deranged. Thyroid profile is normal. He does not have any evidence of microvascular involvement because his fundus and his urine are normal. So what is of concern to us over here? Yes, anybody from the audience? What is worrying us here? Or what is the question at hand? The patient is totally asymptomatic, yes? And he has a positive TMT. That is the question we are addressing. Okay? So let's move on to the next part, wherein Mandeep and Faraz are going to help us. Okay? So what is the first question you'd like to ask them? Very good. Excellent. I'm so happy. So what is the first question? And Mandeep, that's for you. What are the atypical symptoms? You see, when you say asymptomatic, there are certain symptoms which are atypical, but you need to inquire about them. Please, Mandeep, can we have them?
Yes, good evening, everybody. So thank you to the organizers for inviting me. So I think, yes, the question is very relevant, whether the patient is really asymptomatic or not. So we know that for a patient of CAD, the typical history we have the retrosternal chest pain, sensation of heaviness with diaphoresis, but this is not so. I think we are reading since our MBBS days that we have angina equivalents. So there are some symptoms which suggest CAD even in the absence of a typical chest pain. And we should always ask about the history of these symptoms, and these include breathlessness of any sort on walking, exertion, at rest, on lying down. Breathlessness is an angina equivalent. If a patient has breathlessness in a setting of hyperglycemia, yes, we should think of CAD. Then second, the patient having nausea. So many times we see the patients who ultimately diagnosed as CAD, they are taking proton pump inhibitors for the discomfort in the epigastric region. So that discomfort, that nausea, that irritation, sometimes they are misdiagnosed to have gastritis. If the patient is not responding, then one should always think of CAD in a patient having nausea, irritations. Then fatigue. So if the patient is complaining of persistent fatigue, that is another indicator that we can think of coronary artery disease. And the fainting. So these are the 8 angina equivalents or atypical symptoms that we should always probe when we are suspecting CAD in the patient. So in this patient, he is asymptomatic, but we should always ask these questions, this history, to say that whether he or she is really asymptomatic or not.
Thank you, Mandeep. So please note, very severe fatigue, extreme fatigue, even like what he said, faintness, like lightheadedness, indigestion. I think that's another very important one, because you rightly said, for us, a lot of cardiologists, they give a lot of PPIs, don't they? Because we're never sure whether it's actually indigestion or whether it is actually because of heart problem. So these symptoms, please don't neglect them. One of my senior colleagues said to me that her maidservant who has diabetes, long-standing diabetes, around the same age, she complained of extreme fatigue. That's it, nothing else. And being an endocrinologist, my colleague herself, she immediately had an electrocardiogram taken, and that showed changes. So even this one subtle symptom, which he said is an angina equivalent, should be taken into consideration. So look for those subtle symptoms which you may not think are typical angina. So for us, how do we assess the cardiovascular risk in patients with diabetes?
So, thank you first to the organizers for having us, and good evening to all of you. So, the problem with coronary artery disease and diabetes is that it is difficult to diagnose, it is difficult to treat. So, what is most straightforward is assessing cardiovascular risk in these patients. Not all patients with diabetes have a similar cardiovascular risk. So, we need to stratify the level of cardiovascular risk in these patients depending upon the associated comorbidities, the duration of diabetes, etc. So this is a very useful table which I found in the latest European Society guidelines on diabetes. So if you look at this table, simply having diabetes pushes you to a level of moderate risk, far above the risk that a normal population in general has. So once you're a diabetic, then you have a moderate risk of coronary artery disease. The moderate risk here means that you have a 10-year risk of cardiovascular death less than 5%. Then high risk, the risk is about 5 to 10%. And then very high risk, more than 10% risk of CV death. Mind you, this is not just CV event, CV death at 10 years. So let us look at what the very high risk patients are. These are patients with diabetes and established cardiovascular disease, or patients with target organ damage. Now target organ damage can be proteinuria, can be retinopathy, but interestingly it also includes left ventricular hypertrophy. You get an echo done, a patient has a left ventricular hypertrophy, diastolic dysfunction, all of these come in the realm of target organ damage. Then presence of associated risk factors such as obesity, smoking, hypertension, all of these add to the risk of additional risk to diabetes. And then the duration. So once you have had diabetes for a period of more than 10 years, you're automatically at a high risk for cardiovascular disease. So it is important to stratify these, because this stratification can guide one to go for downstream testing. Now it's not possible to do TMT for all the diabetics. We have a huge number of diabetics. It's not possible to do a CT angio or a coronary invasive angiogram for everyone. So this stratification helps us to selectively choose the investigative modalities.
Thank you. I think for us that was excellent. This is very important, this risk stratification, because this is part of the answer to the question that we are trying to address from the very beginning, right? So the duration of diabetes and the age, these are two very, very important things that you should remember from this slide, okay? Now let's move on to the next part. And as South Asians, हम लोग तो बदनाम हैं ही हैं. Why? Because we have more of CAD related mortality. Okay, so there are a lot of reasons for that which we'll be coming to later. But as a whole, South Asians are prognostically very bad as far as CAD mortality is concerned. So, Faraz, can we continue with you, please? What are the features of coronary artery disease in a patient with diabetes as compared to a non-diabetic?
So, as I said, they're tough to diagnose, they're tough to treat. So I'll just give you an example. So this is an angiogram. You don't have to interpret it, but just look at the arrows. This shows the most important coronary artery that all of us have, that is the left anterior descending artery, or the LAD. Look at how diseased it is. It is diffusely diseased. So the problem with such kind of arteries is that it makes our job very difficult as interventional cardiologists. So there's no place to insert a stent. You can only place a stent when you have a normal island distally and proximally, so that the stent lands in a normal vessel region. So, and the other problem is that when you send such a patient for a CABG, surgeon finds it difficult to place a graft. So if it's a very diffuse and thin vessel distally, there's no way that the surgeon can place a graft. Now contrast this with the artery on the right. So this would be the profile of, usually the profile, these are not absolute rules, but this is usually the profile of a non-diabetic patient. So this is how the arteries are. Although you have disease somewhere higher up there, you can always place a stent. It's easier to treat. So having diabetes makes our job of treating coronary artery disease very, very difficult, particularly when it comes to placing stents as well as for placing grafts. So this is one of the major problems. And ma'am, if we can go to the next slide, there's another issue that these patients face. There's the issue of diabetic cardiomyopathy. So regardless of coronary artery disease, if you have diabetes, there's a lot of fibrosis which happens around the vessels, there's a lot of fibrosis which happens around the myocytes, which results in a fibrotic heart when you compare it with a normal heart, and which makes relaxation of this heart very difficult, something known as diastolic dysfunction, which tends to make the patient breathless. So although the patient doesn't have coronary artery disease or LV dysfunction, he has diastolic dysfunction, which produces breathlessness and impairs his quality of life. So this is how tough diabetes makes coronary artery disease as well as the left ventricular function. So I think this should answer your question.
Excellent, Faraz, that was great. So what have you learned now? So our coronary arteries are smaller, we have more severe, we have more extensive, we have more diffuse disease, we have more of calcification. And even when it comes to collaterals with chronic myocardial ischemia, we develop very poor collaterals. So there are a lot of differences which we have. So that is why we are inherently susceptible to more of coronary artery disease and the associated morbidity and mortality. So, Mandeep, is there a benefit of non-invasive CAD screening in patients with diabetes?
Yes, so we have these non-invasive modalities, like we have CT angiography, in which we do not, it is non-invasive, we go for CT and then we look for the calcium score, like CTM calcium scoring. So these modalities, they are now coming up, and because of non-invasive, people sometimes they go for these investigations. But the role of these investigations in asymptomatic patient is only for the risk stratification and calculation of the risk. Beyond that, it has not shown to help us. That means, let's say if an asymptomatic patient goes for this investigation, let's say he or she has a high calcium score, we intervene in these patients, let's say we go for the coronary angioplasty, the outcomes are not better as compared to the individual who is asymptomatic, has been treated adequately, meticulously for blood pressure and dyslipidemia. So these modalities, they have the role as far as the risk stratification is concerned. They may help us to decide which patients we can put on the antiplatelets as primary prevention. Further, their routine use also leads to the radiation exposure. So asymptomatic patients, CT angiography, CT coronary calcium score, there is no role for treatment purpose.
Thank you. Thank you, Mandeep. As far as Indian data, the patient got a TMT done for his insurance purpose. So what about TMT? So we have Indian studies, we have from Maharashtra, we have from Karnataka as well, so which tell us that at least in India, TMT is cost effective, it is relatively safe as a screening modality for coronary artery disease. But let us see where we come to at the end, should we or should we not do it? For us, is there a high risk population subset? We are talking about risk stratification all the time, but is there any high risk population subset in whom screening is recommended?
Actually, there's no clear recommendation, but it makes perfect sense to do downstream testing for coronary artery disease in this particular subset. So say somebody already has peripheral arterial disease. Now the fact that one vascular bed is affected by the disease process means that there's a very high likelihood that the other vascular bed is also probably involved. In addition, in a patient who has proteinuria or renal failure, it makes sense to actively seek for the presence of coronary artery disease regardless of symptoms. And another area is that taking forward Dr. Mandeep's point, coronary artery calcium per se is not, it's not to be pursued routinely, but it can be used as a risk modifier. So as I told you, that you have to substratify these patients based on their duration of disease, associated risk factors. So in case you want to further stratify the extent of disease, or you want to guide downstream diagnostic testing, this is where the role of coronary artery calcium comes in. But having said that, peripheral arterial disease, proteinuria, renal failure, these are some of the patients in whom an active CAD screening can be pursued.
Thank you. What about obesity, patients who are morbidly obese during pregnancy and pre-anesthetic? I think these are three categories in which screening is also extremely important and it should be considered. Okay, now we move on to the role of aspirin. Mandeep, for primary prevention in patients with diabetes. So now we are trying to look at the patient as a whole, not just the coronary artery disease part.
Yes, so a very clinically relevant question. So I think in secondary prevention, when the patient had MI, there is no doubt the patient should be on lifelong antiplatelet therapy. After acute coronary syndrome, dual antiplatelet therapy for 1 year, and sometimes beyond that if the disease burden is high. Otherwise, a single antiplatelet therapy for lifelong after the episode of myocardial infarction. But for primary prevention, there is controversy. So this controversy has two parts. One is whether there is beneficial effects in terms of preventing the cardiovascular morbidity and mortality. The data is not so convincing. So the data, it is not categorically showing that in asymptomatic patient, you give antiplatelet and then you will have the reduction in the cardiovascular events. And secondly, there is an increased risk of bleeding. So if a patient is taking antiplatelet, let's say the patient is taking aspirin, there is an increased risk of bleeding, particularly the gastrointestinal bleed. So I came across one study, the ASCENT trial, in which they give aspirin 100 milligram in one arm and placebo in another arm. They followed this patient for 7 years, and the risk of GI bleed was 4% in this patient over 7 years. Although there was a slight reduction in the cardiovascular morbidity. So according to the American Diabetes Association 2022 guidelines, what I found that they recommended the aspirin for primary prevention in patients between the age of 50 to 70 years. More than 70 years, the risk of bleeding is high. So their careful usage, otherwise 50 to 70 years in male and female, plus one additional cardiovascular risk factor, and that means family history of premature coronary artery disease. That is, if in a family a male has a CAD less than 55 years of age, or females males 55 and females 65, hypertensive, smoker, dyslipidemia and proteinuria. If a patient has these risk factors, any of these, then we can start the patient on antiplatelet therapy. But we have to see that whether he or she has increased risk of GI bleeding or not. So if there is any history of peptic ulcer disease previously which is bleeding, or the old age more than 70 years, so we should be very careful. So this subset of 50 to 70 years with the risk factor, then we can go for the antiplatelet therapy. Regarding the dosage, So in the US, they are using 81 milligram per day. For in our setting, we can go for 75 milligrams. So low dose aspirin in these patients can be used as a primary prevention, provided we are not increasing the risk of bleeding, particularly the GI bleed.
Thank you. So, so only for patients high risk of coronary artery disease with low risk of bleeding. So that is your take-home message. But like I said, we're trying to manage the patient here as a whole. So what else? You've already said that. Just to reiterate, we also need to worry about the lipids, yes.
Lipids, hypertension, glycemic status, lifestyle, exercise. So these are very important things. Comprehensive management is required. If we are managing all these factors, they are as good as going for invasive screening in these patients.
So everybody is ready for this question? So which of the following statements is true? Statins should be avoided in patients with pre-diabetes because of the risk of associated new onset diabetes. In patients with very high CV risk and LDL-C target of less than 70, statins are safe during pregnancy. If the target LDL cholesterol is not reached, combination therapy with ezetimibe is recommended. So which of the following statements is true? No prizes, but we'll clap for you if you give the right answer. Anyone? Please stand up and say then. Next, anybody? Next answer. You say only 2 is true. That's what you're saying? The next, anybody else? अरे खड़े हो के बोलो. No punishment. Number 4 is true. Yes. Anybody else? So we have only three bidders. Faraz, over to you.
I think the residents from AIMS, they got it right. The 4th statement is true. So
now, can you also explain why the others are not?
Yes.
I think that's very important.
Yes, I'll do that.
Yeah.
Regarding the first statement, statins, the thing is when you give a treatment, you always talk about the population level impact. So when the role of statins in terms of the benefit far outweighs the small risk of statin associated new onset diabetes. So regardless of that risk, statins are to be given in that subset, keeping their lipid profile in mind. Coming to the second statement, in patients who are at the highest risk, that is at very high risk, the LDL target is not 70, it's even more stringent, it's 55. Statins are to be avoided in pregnancy. And yes, in case you don't reach the LDL cholesterol target, you can supplement statins with ezetimibe. And in case you're not able to reach your targets, despite that, you have newer drugs in the form of PCSK9 inhibitors. So I think the 4th one is...
I thought this was an important question, so we went into great detail, right? Now this is very short and sweet, and I want the answer. Everybody has to get it right. What dose of atorvastatin should be initiated in patients with diabetes at a very high CV risk? 5, 10, 20? 1. Number 4. Next. Number 4, everybody's number 4? Good for you. I think you've already come prepared. Thank you so much. So I thought this would be a little bit interesting in between. So now we can continue with our presentation, and because the clock is ticking, we have to hurry up. So we have concise, crisp, small answers now. So for us, is there a difference in treatment strategy for CAD in patients with diabetes as compared to non-diabetic patients?
Sorry, in fact there is, and it actually pertains to this subset. So in case you have multi-vessel disease, there is often a preference, especially among patients, to go for the non-invasive therapeutic modality, that is a coronary angioplasty. But this is one group in whom there's a clear advantage of coronary artery bypass grafting. So in case you have a patient with multi-vessel disease who is a diabetic, then the first treatment option that is to be offered to the patient is CABG, regardless of the fact that these patients sometimes suffer from delayed wound healing because of their diabetic status. This has to be the treatment modality of choice. And there's an overwhelming reduction in the primary endpoint. This is from the landmark Freedom trial, which has shown a clear benefit of this therapeutic modality.
Okay,
So I think
we'll
this has to
just-
be kept in
Yeah,
mind.
so what now the next question is short, again very short answer here, Mandeep. Utility of ankle brachial index in assessing cardiovascular health. I think you've already answered it. Just to clarify,
So ABI is just a risk modifier again. If the ABI is less than 0.9, it adds to the risk. But it is not a criteria that we should go for the further imaging and testing and treating the patient for CVD. So it is-
perfect. Now the international as well as Indian guidelines, just to reiterate what we have said, one statement each from Mandeep and Faraz.
So the international ADA 2022 says that screening is in asymptomatic individuals is not required
Not
because
recommended.
if you treat meticulously blood pressure, blood glucose, antiplatelets, lifestyle, you are getting the same benefits as that if you are screen the patient and go for invasive revascularization.
Absolutely, that's what we are trying to say. So it doesn't help. So look after all the other things first. Unfortunately, see, Faraz is not going to talk to me after this is over, because I tell my patients, see, if you go to Faraz, he'll write so many medicines for you after you've had an event. But you just take my medicine so you don't have an event. So the whole purpose is to prevent those complications from occurring. So we look after all the risk factor components. So Faraz, would you like to add something to this?
The one drug that I think all the diabetics, especially the middle-aged diabetics, should be on are statins. The reason why routine screening has not shown a benefit is that the benefit of statins is already received by these patients, because most of them are already on statins. So there's no additional benefit to be found from revascularization, because we've never been able to show a mortality benefit with stenting in patients with chronic angina. So whatever benefit that has to be obtained is obtained by this single group of drugs, that is these statins. So that has to be kept in mind. Regarding the other recommendations, the same thing, at the risk of repeating, routine screening is not indicated. It's important to risk stratify. It's further important to sub-stratify that risk and then decide on downstream testing. And statins should be given in these patients, except at the extremes of ages, statins should be given.
Thank you. I think we've answered your question. So now you are going to answer the question that we started out to answer. We're coming to you. We still have that clock ticking and we have a lot of time as far as question answers. So now you are going to answer unanimously. Should an asymptomatic patient with diabetes be screened for CAD routinely? What happened? Everybody's gone to sleep. Yes or no? That's what we started off to address. No answer? I'm sorry, we've done a very poor job, Mandeep and Faraz, and that's all my fault. So what is the right answer, Faraz and Mandeep?
No answer. You have said rightly no.
Yes, one person. I heard only one lone voice. Oh God, I thought you people were understanding everything we are trying to convey. So the answer is no. Yes, now we can have questions from the audience. Please.
Yes. I think we are in the same when we started. We didn't discuss about the case. Like TMT was positive in diabetics, and you didn't recommend what to do. That's
Yes.
we should go for CAG or we should.
I'll tell you that.
We have not-
I'll tell you the problem with this case. Now, if we were to go by what the guidelines say, you wouldn't have tested this patient in the first case. But now this patient has already got himself a TMT done, and unfortunately something odd has cropped up on the results. Now you're bound to do downstream testing regardless of the guidelines, because the guidelines are meant for the population at large. But this is an individual case. He could have very easily come out with a negative TMT, right? In that case, we would have reassured ourselves. But the fact that he's come out with an abnormal result binds you to do downstream testing in this patient to look at the extent of coronary artery disease, and then you decide your treatment modality or the way of treating coronary artery disease in case you find it. So this is kind of an outlier. But to answer your question precisely, now you're bound to do downstream testing in this patient. So what modalities to be done? Since he's already had an abnormal functional testing. So TMT is a functional testing. You've made the patient run. And this is an example of functional testing. A CT angiography is an example of structural testing. So once you have an abnormal functional testing, you go in for an invasive angiogram. There's no point in doing a CT angiogram because you have to do a definitive test. So you do an invasive angiogram and then you decide on what is to be done based on the results of that.
But what are the chances of a false positive? And we are just discussing TMT. I think that's very important.
TMT, the reporting of TMT is subjective. So you look at ST depressions, what somebody may perceive as a downsloping ST depression may be in fact a horizontal ST depression, maybe in fact a slightly upsloping ST depression.
There's a lot of subjective
unless the ECG changes are very manifest, it's it's likely that the ball may fall on either side of the line.
Absolutely. So this is one
but the data is about 60% is false positive.
That's what I'm saying.
About 60% is false positive.
That's a big rider.
Big rise.
See, अगर दोबारा करते तो क्या होता? Yeah, I mean, maybe not everything comes out negative even after, at the end of the day.
Second question is regarding anybody having diabetes with more than 40 years of age. Why not have a routine TMT testing?
Because because it's very difficult to apply that.
Because in a lot of companies, I think Army or maybe in the police
that's true, they are doing.
This is there, they have got recommended that in all cases, annual checkup, there should be a TMT.
I'll tell
so
you
why,
that.
what is the harm? I think in a lot of cases,
the problem is that we are a country of 1.3 billion. Not all of them are enlisted in the army. It's very tough to employ in a blanket fashion diagnostic modalities like TMT for everyone. It is very difficult. You always, even in developed countries, they always try to find the patients who are at the highest risk and who will derive the maximum benefits from therapy.
Yes, my point is something different. You are doing something else. I am talking like somebody, even out of 100, we get even one case of TMT positive, and we can prevent the death of that person or maybe the complications. So what is the harm? If they can afford it, they can do it. If they are not able to afford it, they will not do it.
There's no harm. There's no harm. But when you do a cost-benefit analysis, it's never going to work out in favor of benefit. It is always, the cost is always going to be heavier. So to detect one patient, you are having to screen about 100 patients. Taking your example forward, it is a very difficult job to simply apply these on a population level. You always will have to stratify, select the highest risk based on the patient's demography, and then go for downstream testing.
Okay, thank you.
So thank you. You've been a wonderful audience, and I'm sure that you've enjoyed Mandeep and Faraz answering the questions. And thank you to the organizers for this invitation. Thank you very much.